Welcome back, everyone, to another fabulous episode of HealthCare Trailblazers. I am very happy and honored to be here with the wonderful Henry Denis. Henry is a fascinating individual with a great career in healthcare. He started actually on Wall Street, and he finds himself today on the cutting edge of data analytics and consulting in healthcare. Lots of clients, very successful. Henry, thanks so much for joining us today.
Thank you for having me, Mendel.
So I kind of gave a very brief overview of what you do. Give us a bit of more of a description of your journey, and then we'll kind of dig into how you got started.
Be happy to. Thank you so much. So graduated from Brooklyn Poly, today called NYU Polytechnic School of Engineering in 1988, and then worked as an engineer. I got a degree in computer engineering actually. And ended up on Wall Street, and I did a lot of data center building for high-performing electronic trading applications. So that lasted a while, and then I did a bit of electronic discovery, again, same type of high-performing electronic platform for electronic discovery in legal services. And in 2008, so we had a crash on Wall Street, as you know. And at the same time, something happened in this country wherein high-tech became the law in January 2009 with Obama administration, and everybody started to move to electronic medical record aggressively. There was a lot of money put out there by the government, and with all of our experience and our team available, so I thought, hey, why don't we take that experience and move over to healthcare and provide that expertise? Well, it was quite a bit early. Actually, too early, and I'm not even so sure that today healthcare is where Wall Street was then in terms of high-performing applications. I don't think it's needed. I don't think that it's ever going to get there. So that's our entry into healthcare, and what really happened is that within a very short time, we became a consulting company. We did a bit of installation of EMR, but we became expert in the programs that came out and helped a lot of the practices meet the compliance requirements from meaningful use all the way to what is called today pay for performance and value-based care. And along the way, by 2021, we put out our own data analytics platform and branded that under Medical Informatix before Inc. And now we have a data analytics platform that is being used by medical practices to manage their value-based care programs and actually, earn the incentives.
Very cool. So let's go back to Wall Street. You started there. What did you like about Wall Street? What did you not like about Wall Street?
High pace, high performance, and high everything, high energy environment. So certainly exciting as a young guy. Certainly a fantastic opportunity to be working with the latest and greatest technology. Money was never an issue, right? So it was always speed and speed and speed and speed. A fraction of a microsecond is worth the investment. So that's really the actual excitement. And on the downside, obviously, you're not available a whole lot, to your family as well, right?
Right. Did you have kids at the time?
Yes, I did. I was married very young, actually, 2 years out of school. I was married. So I did have a family, still the same wife, and my children are grown and almost out of the house. But at that time, they were very young, and it required a lot of sacrifices. Back then, maintenance was, you had to be on site. It was a physical thing. And all maintenance had to be done outside of business hours. So it meant a lot of night and weekend work. So that's what I did not like about it, but it was a necessary evil. I mean, we had to be up and running 24/7, 365, and performance was the key term. So that's the part that I didn't quite like. But hey, towards the end, it became easier when VPN became, a la mode, right? So we were able to do maintenance from remotely. It was still after our work, but at least we were able to sit at home and be able to do it from the comfort of our own home.
Right. Fascinating. So so then you jump into healthcare. You said that it was not what you were expecting. What were you expecting that healthcare would look like?
Well, walking into healthcare, understanding that we wanted to move from where healthcare was pretty much on paper, some electronic, to full-blown electronic health record and connectivity and inter-exchange of communication, the normal stuff that you see on Wall Street. That's where I expected healthcare would have moved towards. So I saw the opportunity to really bring a lot of experience with healthcare and move that process forward a bit faster. Well, far from it. When we're dealing with a lot of government regulation, it's a very regulated environment. Nothing moves fast. All the promises of interoperability that were talked about at the beginning, we still have not seen them fully implemented. It's still fragmented, and there are still a lot of restrictions in terms of having access to, a medical record in complete format. So it's still siloed, and it's going to be a challenge to get to the point where Mendel can say, I have a complete record of my own affairs in the medical world, and I can have it, anywhere I want. I can have it on my phone or in the palm of my hand. It's complete. It's just not there today. The promise has been made. A lot of money has gone into it. A lot of effort has gone into it, but it's not where we need it to be. And I think this is the only industry, frankly, that is like that today.
Got it. So let's dig into the challenge a little bit for people that are not as familiar with the inner workings of where we wanted to go with this, where the government wanted to go with this, and where we maybe are at today. Let's dig into the challenge a little bit. So what does the landscape of data availability and proper aggregation and storage look like today versus where it should be?
So what we would have expected by now is that you decide to leave, let's say, Dr. A as your primary care, and you go to Dr. B. You would expect Dr. B to be able to, with your permission, obviously, see where you've been. And it would all be aggregated in one place, and then there would be a full chart on Mendel, right? That's not the case, okay?
That's definitely not the case.
It's not the case.
No, we're still spending hours and hours on the phone, right, calling back, waiting for the person to fax over the medical record.
How about the very basic of things? So if I go to Dr. A, they ask me to fill out this entire set of intake paperwork, right? Today I can do it electronically, or some people say you still do it on paper. If I go to Dr. B's office, why can't you just pull that information? Why are you asking me to fill it out again? And I go to Dr. C and the same thing. This is at the very basic level. This information doesn't change. Why in the world are we still asking patients to do the same thing over and over and over again? Then it comes to what belongs to you and what belongs to the insurance company. It's clear. It's your personal health record. It belongs to you. You should be controlling it, and you should be able to give access to whomever you want to give access to. But do you actually control your PHR, right? So it's still not clear that we really have a personal health record. Obviously, many companies attempted, to come up with a solution, even the big ones, right, like the Google. And yet we are at a point where we don't own our personal health record. We don't have control over it. We cannot share it as we please with whomever we please and remove access from the people that we don't want to have access to. That was the promise, and that's where we would have believed today, in 2022, we would be. So, and there are a number of reasons for this, obviously, because the information is fragmented. Every doctor's office has their own EHR. It's not a single one. They don't talk to each other, right? There are supposedly standards that would allow data exchange. There are health information exchange organizations. There is the superhighway that would allow data to flow from one another country to another. So, all this infrastructure is in place. But protocols for exchanging information, we have still yet to figure out how to make that simple enough that I can own my PHR and really have the information available to whomever I want, wherever I want, whenever I want.
So what are some of the ideas out there? I mean, perhaps there should be similar to a social security number. When people are born, maybe they should have a PHR number, and then you have one EHR ID and everything floats there.
It could be. There have been many proposals, but it's not that we don't know how to build a single repository that people have access to and can control, right?
Okay, so what's the holdup?
It's all the laws that have pre-existed electronic health record, right? And then they are embedded in HIPAA compliancy in the first place. And now there is another business problem as well. Remember, the information is locked into these electronic health record systems and that are controlled by some of the giants of the industry, right? So they're not exactly going to be very willing to let you have all of your data. That means you can jump from one vendor to the next vendor, and that makes their business vulnerable. So there are the rules and regulations, and there are the laws, and there are some business aspect of it as well. Although the laws are on the books that says this should happen or this should not happen, but the actual implementation is not exactly as transparent, and people are not forthcoming to making sure these things happen easily.
Do you think that for the general population, there's more of, like, would this be, what you're talking about on the one hand obviously sounds incredibly convenient, and anyone that's tried getting a medical record from one doctor to another knows exactly what you're talking about. But do you think there's, from the general people, do you think that there's some serious privacy concerns when it would come to something like that? Or is the holdup strictly the business side, like you mentioned?
I don't think so. I don't think it's on a personal level. I think people have moved way beyond accepting, that sharing of information is normal, all the privacy and so forth and so on, especially the newer generation. I mean, it's not a concern anymore.
Yeah, anyone that has TikTok on their phone should be very comfortable sharing everything about their life because
just about everything.
They have it already.
Exactly. So data privacy, security, I don't think that's a concern any longer, right? I think that the two biggest hurdles are government regulations and obviously business, right? So when you have a captive audience and they have a very hard time moving from, this to that or their one, then you're going to keep them as there as long as you possibly can, because obviously, that's your business, that's your income. So these are the two biggest hurdles that I think exist out there today.
Very interesting.
It's not an easy process to move from one EHR to another. I can tell you that.
Yeah. You're saying from a technical perspective.
Oh, from a technical perspective, right.
Yeah.
And financial perspective as well. Yeah. Right.
So I think we'll kind of come back to this, but let's go back to, all right, so you started a business in healthcare. You jump in and the industry looked nothing the way Wall Street obviously looked, as far as the fast-paced environment and the flexibility and the, being able to be agile and stuff like that. How'd you pivot? What did you do once you came to that realization?
Well, when we came to that realization, two things happened. We became a pure consulting company. So we became experts in all the government programs and private programs that were coming out, all in regards to compliance. So with the data, it became possible. So the very first one was called meaningful use. So our first contract was actually in the state of New Jersey with New Jersey High Tech and adopting electronic health record systems and then becoming meaningful use compliant. So we contracted with NJ High Tech and we were called field agents. So we came out as one of the first, depending on the three categories. In one category was first, another company was second, and then the other category were second, and they were first. So we did a lot of that. And then that's the genesis, really, of the expertise, which still exists today as we are navigating what is called the HealthCare Worker Bonus Program in New York State. I don't know if you know about that, but New York has just come out with a program wherein they are directly providing bonuses to healthcare workers. Obviously, it's a good thing following a pandemic to encourage people to come in, to encourage people to stay, and to really say thank you. However, it's complex, right? So that's what we do. We jump in and we render something that is very complex for some practices to something that is manageable. So this is what we've done and we've been doing since 2010. So taking those complex programs, turning them into something simple that allows the practices to become compliant and get the incentives. And we stand by the practices as well when there are audits, because generally speaking, audits will follow. The Office of the Medical Inspector General in the state of New York will knock on your door and wonder, did you follow all the rules and regulations when we give you the money? So we stand by them. So that's one side of the business. But by 2015, something happened. So with the Medicaid redesign program, New York State came out with what is called the DSRIP program, Delivery System Reform Incentive Program. And that was the first time that practices were paid based on outcome, true outcome. So they were given specific measures and they had to hit specific percentages in order for them to get the incentive dollars. Panic. It was an industry that was not used to that at all. What do you mean pay for performance? What do you mean that I have to have 75% of my 2-year-old fully vaccinated? What does that mean? So although doctors are really good at taking care of their patients, but they're not really good at necessarily documenting in a manner that would allow for reports to be pulled from their EHR and submitted to the other side. So we became the middle people. So we wrote an application. It was Excel-based application and a lot of manual intervention required. And then we got our clients through the 5 years of DSRIP and they made some money and it was all good. But as we were moving through these 5 years, 15 to 15-20, it became clear that the industry had shifted tremendously, right? Because out of those 5 years, we were supposed to be in value-based care. Now, value-based care is a scary term for some people because it can take multiple forms. It could simply be shared savings. Great, wonderful. You may make more money, but you cannot lose any money, right?
Right.
So that's called upside risk only. But there could be downside risk, meaning that you can make money or you can lose money. So if you are not meeting the requirements, you may have to pay money back. If you are in a program wherein you are given a certain cap, right, 15% above what was spent last year, and you spend 20%, well, the 5% is on you.
Yep.
And it may be full risk. You are given a pot of money to manage those patients. And if you manage outside of those dollars, guess what? It's on you. So here we are. Different flavors have started to come out. And we came to the realization that a lot of those practices do not have the technology that is going to be allowing them to manage those contracts. It's as simple as that. So now we started to look for real solutions because our little application was not going to cut it, right?
So is this where the ACO was born?
ACOs were born out of the Medicare side, very similarly in terms of contracts, right? Upside risk, downside risk, and then at some point moving to full risk, but it's under Medicare. Yeah. Correct. Same concept. So, but we were really in state working with the Medicaid programs in New York State rather than the Medicare program, but very similar concept. Okay. So when we realized that our application was not going to be able to cut it, one of our tasks was to find applications that would help our clients. So we had two requirements, practically speaking. It's got to be affordable because we're dealing with the independents. They're not going to spend millions and millions of dollars buying or building, a platform. And it had to be easy to use, meaning that they don't need to go and hire engineers, right? Data engineers in every single practice to be able to run SQL queries every day to tell them what to do. So we couldn't find anything. I'm not saying that nothing existed, but we didn't find them. What we found was complicated programs that were very expensive. And that's not what our clients wanted. So we ended up building one. So by 2021, we had the platform out and we branded it on the Medical Informatix, Before Inc. So that's where we are. And the platform, you don't have to buy it. You don't have to build it. It's there. And it met those two requirements according to the people that tested with us and set out to help us, right? Being affordable and being easy to use.
So what practically does the platform do for a practice today?
So a practice now has very little choices but to enter into a number of pay-for-performance programs. So a single practice may have 2, 3, 4, 5, 10 of these programs, and they all work differently, and they all work similarly in the sense that you are given a number of gaps in their codes based on certain criteria. Generally speaking, could be age, could be diagnosis, or what have you. And you are certainly going to be asked to meet a certain threshold. So I want 80% of your 3-year-old to be vaccinated fully. I want, the blood pressure to be under control, 140/90. I want, colonoscopy to be done based on certain age and so forth and so on. And you have to have the means of tracking every service that is rendered, and you have the means of identifying the people that have not received the service, and you have to be able to do automatic outreach, regardless of the format, text, email, phone calls, or what have you. So that's what the platform does. The platform aggregates data from all these different places, bring them into one single place. And our clients told us, look, we are doctors. We went to school to see patients. Don't try to make us technologists. Tell us what to do. So we distilled it all down to one thing. This is the list of patients that you're going to have to see today. And as you're seeing them, provide these services. So if there is an integration, we can push a notification to pop up directly into the patient's chart. If there is no notification, there is a list. You have access to a portal. You can download the list, and you can do whatever you please to do with it. You can have, your staff download the list ahead of time and then enter the notifications manually. Or some practices still have paper charts, and you can just write a note on a sticky and then stick it on that chart, whatever it takes. But we tell them every day, we give them guidance every day. As you're seeing these patients that are on your appointment book, make sure that you close these gaps. And that's really all we ask you to do. The platform will do this.
If they're slapping a sticky note on a paper chart, how does that reflect back in your, for your reporting?
Oh, because they have an EHR. It's that they are hybrid still. They are still not completely comfortable letting go of the paper chart. So the data will find itself in the actual EHR. But what makes us different, Mendel, is this. Most platforms wait to receive the actual utilization data back from the insurance company. We don't. So as data is leaving the platform from a billing standpoint, we catch this information, right? Generally speaking, it will be in the 837 file format if you are in the industry, right? So we look at every single code that is on this 837 and we render a meaning. Therefore, we don't miss anything. There are a multitude of opportunities between the time the file is generated in the EHR and the file that comes back from the insurance company. So our work is to make sure that all of these codes are processed through a HEDIS engine and credit is given to the practice for closing that gap according to the NCQA rules. Now,
you catch the data and you can analyze it before it even hits the insurance company.
That is correct. Now, we do not get involved into billing. So that's a normal question that would ensue. We don't care for billing per se. We're not a billing company. We're not an LCM company. That's not what we do. The world of fee-for-service is well taken care of. They are our friends. We can complement what they do, but that's not what we do. But we do need the same information that they produce. So now when we analyze the data on the way to the clearinghouse, and then we have the utilization data back from the insurance company, we're looking for matches, right? So if data comes back and it says credit given, wonderful. What we did is exactly what they found, not a problem. If there's a discrepancy, that's where we come in. And then there's an automatic appeals process that is triggered, and then the insurance company has to answer to the question as to why this practice didn't get the credit when we saw that they were supposed to be getting the credit. So that is one of the key differentiator of our platform because we are able to do that reconciliation. Could we do it ahead of time? And, in terms of errors and omissions, because that happens as well, right? The practice do not bill correctly. They don't use the right codes. There are errors, there are omissions. Could we intervene ahead of time? We could. But again, as I said, we are not looking at it from a billing standpoint. We'd rather looking at it from a gap closure standpoint. Hence the reason why we're not intervening ahead of time.
Very cool.
We are not in the world of fee-for-service billing at all. That's not our world. Our world is strictly in pay for performance, in quality, in outcome.
Got it. So you give practices the tools to be, to very easily and comprehensively understand and get better at their quality measures.
Practically speaking, yes. As simple.
Very cool.
Yes. Great. And all those things that would require a lot of human intervention, we have automated them as well on the back end, because at the end of the day, right, they have to be done. Right.
So give us some examples of that, because that's always the biggest hurdle for the doctors. Technology is great technology, but if the doctors, reporting is only as good as the data that you can feed it, right? Feed the system. So at the end of the day, I think it's very difficult sometimes to get doctors to actually do the action, to actually just put it in there,
And we make it super, super, super easy because it's very visible. So let's say that we start working with a practice. And the first thing that happens is we're going to get your data, right? And we're going to analyze it through the engine. And we're going to come back and we're going to say, okay, let's review this. We call them, opportunities. Let's review these opportunities for improvement. And when you look at them, we categorize by column. So let's just take a measure, right? A quality measure would be called weight, nutrition, and activity counseling, and whenever a BMI is out of range, right? So now it's defined by NCQA as having 4 components. So you have the BMI, obviously, and then you would have the nutrition counseling, you would have the activity counseling, and obviously you have to have a well visit. So what we would do, we would put each categories of code in one column. So anything that doesn't match, it would be a blank. So if there is an error, there would be a blank. If there is an omission, there would be a blank. So when we call the practice and we say, okay, look, we've analyzed your data, we've analyzed your coding, and this is what we found. You should see the eye-opener. Are you sure? Yes, we are. And this is the reason. So we go through that process, and it is amazingly effective, because the next time they come back, guess what? There are no holes. And when you do that for 60 days and 90 days with a practice, they become perfect at coding for quality, because not all quality code is a payable code. In the world of fee for service, you want to get money for every code. In the world of quality, that's not necessarily the case. You may want to just have the code to close the gap. And that's a major hurdle for practices today. They're getting it because they understand. And the worst that can happen, honestly, is when quality and fee for service collide. The code that you would use to get the extra dollar on the fee for service collides with the quality code, because they don't want you to use that code for quality. But at the end of the day, you're banking that you will get a lot more in return when you get your quality check. So that's when there is contention, because the fee for service people will want you to make the dollar today, when the quality people are telling you, no, let's bank that dollar and get $2 down the road.
Yep. Do you think that sometime in the next decade we'll be in a place where everything is risk and value based and there's no fee for service anymore?
It is the direction that it's taking, and I've lived long enough to know that everything goes in cycle. So it's not completely new, the whole concept of risk. It's not completely new, the whole concept of the next level on top of you wants to know their budget, right? So back in the day, we used to have capitation. So it used to be the risk. I didn't know that. Okay, yes, but it was not at the level of the practice necessarily where the risk was, sitting. So when we had states entering into contracts with managed care plan, the risk was passed from the state to the managed care plan. So the managed care plan was given a pot of money to manage the patients. Right. And obviously there are always some caveats and so forth, but the risk was sitting with the managed care plan. So now, beforehand, it used to be the state Medicaid programs managing the risk. So now the states don't have to manage it anymore. They pass it on to a private company, and the private company is managing the risk. But the state now has a budget, and they know more or less what it's going to be. So this is the new iteration. Now the risk is being passed from the managed care plan, the insurance company, the private company, to the doctors. But doctors are not set up for that at all. Okay.
So it seems to me that there's one more iteration left where you just start paying people to take care of their own damn selves.
They probably are going to
start
get
eating your vegetables, people. Here's $10.
Because there's only one level left, other than that, I don't know. So as the risk is being pushed down and down and down. However, you're already seeing a lot of people taking charge of their health, right? So the whole concept of direct contracting is the new model. There is a reason why Google just spent a few $1 billion buying a healthcare company, because they are involved in direct care model, right? So you pay money.
And just in the last 2 months, both Amazon and CVS have bought, which is interesting. I've bought, companies that I've been following for a while. Amazon just bought One Medical. I don't know if you saw that. And CVS just bought Signify Health, which is either Signify or Caravan became Signify. So you see the big players are definitely pushing, and obviously Amazon with their pharmacy push. So and Walmart's doing this whole Walmart health thing. Yeah. Still hoping to get Cheryl Pegas from Walmart to talk a little bit more about that. But yeah, the big boys are definitely coming in and making pushes in healthcare. You mentioned though that Google had made some sort of effort on what we started talking about, which was one
PHR
housing for all data. What did that look like, and why did it fail, or did it?
I'm not 100% sure as to why it failed, but the concept was exactly that. You have control, and then you take your data and you upload it to Google. And take your data and upload it into Google was thought as being something simple, right?
Yeah.
When was it that it became available that you could go to a portal and pull your data that you would have? It became available, and some people still having difficulty being able to download their, medical record. Now it's up to the patient to demand that from everywhere they go. So everywhere you go, you have a different portal, and then you would be downloading your little piece of your record, and then it would be up to you to load it to your PHR that you control. So too much effort on the part of the patient, especially when the third party, right, that is supposed to make that data available, didn't have any real reason or obligation to make the data available. So the design itself put the onus on the patient, because you would own the information, but you have to get the information first in order for you to be able to build your own personal health record. Follow? So that's
yeah. I mean, you're right. Like no one really thinks of. I mean, I've never really thought it through, but it does sound like it should be really, really simple. When you become a practice, the same way you get, registered and accredited in order to be able to accept insurances, you should basically become a verified, physician. Me as the patient should essentially have, just like in Google Drive, where you have, where you can set permission settings, this and the other. If you're a doctor, you should have to request from me access to my file. I should be able to grant that and remove it as I wish as the patient. And everything lives there and everybody collaborates over there. I mean, obviously you're going to have issues with standardized practices so that everyone's messing with the data in the right way, but I'm sure Google's smart enough to figure that out. You're right, it's very interesting. So government, red tape, and obviously the big companies right now not wanting to let go.
The HRs. Yeah.
Wow.
Yep.
And I mean, are they selling everyone's data? Like, why do they care so much? I mean,
oh no,
they're still going to have a business.
No. Right. They cannot sell your data. They can de-identify your data. They can do, a number of things with it, such as research and so forth and so on. I mean, the whole model of practice fusion being free was, predicated upon the fact that they could mine the data for a bunch of other reasons, and people would pay for that. No, it's not that. So at the onset, there were no standards. So every EHR did whatever the hell they pleases, excuse my French. But at the end of the day, you cannot bring data into an aggregator and not have the means of standardizing that data. Yeah. So now you're starting to have standards, coming out, and now we're starting to have convergence and so forth. So now we can have, we have HL7, right? And we have had HL7 for a long time. So is that the panacea? No. Has it solved every problem? No. We've made some progress, but we're not there yet. So we are not there yet. And that poses.
Do you hope or expect that we'll ever make it to the destination?
Not during my lifetime, probably not. I'm very doubtful. I think that there will be solutions, though, that are parallel, different, more elegant, because I think the public will demand it, especially the newer generation, right? I mean, they're a consumer-driven generation. Everything is on their phone, and they need to be able to shop. So now, if you're going to be in direct contracting model, whether you are the one paying or you are under an employer who is paying, then there's a whole lot more leverage there to be treated as a consumer because you're in a direct payment model, right? So now, the model today is I have insurance and I go and I receive care and the insurance company pays, right? It's still the prevalent model. When the model is direct contracting, then there is a lot more leverage on the part of the consumer. And that's the direction that I see us going. And that's what gives me hope that we will see the industry changing over time to become just like, any other industry, for God's sake. I mean, the paying client has the power.
Right.
Today you're paying the insurance company to give the insurance company your power. So with the direct contracting model, we will see the power coming back to the consumer, to the paying consumer. And then with that, I think we will see a whole lot of the changes because they will be driven and demanded by the consumer. And that's normal. That's how businesses work, right? That's the normal way businesses work, except for, in this industry, right?
Right,
so,
for some reason.
Because the other way is not going to happen ever. I don't think so, because if we expect to get, one mandated insurance company, I don't see it happening. Medicare works for that very reason, right? But I don't see Medicare being expanded, to cover everyone in the nation. I don't see it happening.
Wow, a fascinating conversation. Henry, if people would like to find out more about your services and get in touch with you, where can they find you?
On the web at mifoinc.com, mifoinc.com.
Cool. And you can also, I know Henry's on LinkedIn. I know that much.
I am on LinkedIn. That much, we connected via LinkedIn. Yes, you can look me up on LinkedIn. And my name is Henry Denis with one N.
Henry, thank you so much for spending time today. Really a fascinating conversation and tremendous success and best of luck in continuing the good fight for good data for everyone.
Thank you so much. And I'm honored to be here.